Good. Okay. Good morning, good afternoon, good evening, everyone. Welcome to GASOC Journal Club today, the 20th of January, and we are on an anesthetic focus today, and I will introduce the paper and our esteemed speakers very soon. But before I do that, just a welcome. Firstly, I'll introduce myself. I'm Ryan Els. I'm an anesthesiologist from the UK, but currently working in Uganda. And I'm Vice President of GASOC. I'll be hosting this session today. Assisting me and doing some of the tech behind the scenes, you may see some interaction, is our President, Dr. Nath, who's also worked in Uganda previously, but is currently in the UK. Welcome to the people who are present today. Please put any questions you have in the chat as we go along, and we'll have discussion at the end as well. And it's really a pleasure to have you with us. Also, hello to anyone who's watching this online as well later. Just before we start, just at the beginning, and we'll mention it again at the end, another event that's coming up on the 2nd of February is our Frugal Innovations course. There's a launch date on the 2nd of February, and we shall put an advert up in the chat or maybe at the end just to see the sign up for that. But that's going to be a educational course looking at a range of innovation and research skills for any of the specialties. Any cadres can be involved with that. And more information can be seen on our website or our social. So have a look out for that. That's coming up later on. But let's go on now to the main event for today. Okay, so before we start, I'd like to introduce our speakers, which I have the pleasure to introduce who are joining us today from India. So firstly, can I introduce Dr. Gita Nath? She is a consultant anesthesiologist and intensive care, External Anaesthesia Associates from Hyderabad, from Rainbow's Children's Hospital and Birthright. Previous positions held include Professor of Anaesthesia at CMC Hospital, Vellore in India, as well as consultant anaesthetics at Addenbrooke's Hospital. Areas of interest and expertise include pediatric and obstetric anaesthesia, as well as regional anaesthesia, difficult airway management, ultrasound, and anaesthesia and intensive care. And importantly for this topic, and we'll be discussing later, has been involved as an instructor in many courses, as well as a module editor for PACT and a vast country coordinator. VAST is another type of short course. Ex-president of ISA Hyderabad and ex-president of IAPA Telangana State. So thank you, Dr. Gita Nath, for joining us. Very welcome. Also, the pleasure to introduce Dr. Sailaja, who is also a consultant anesthesiologist at Rainbow Children's Hospital. Areas of interest, again, importantly, simulation, maternal and pediatric, and high-risk obstetric intensive care. Achievements include a member of the Indian Society of Anesthesiologists Hyderabad City Branch, treasurer of the Indian Association of Pediatric Anesthesiologists, had journal publications on simulation, an author chapter on CPR updates in pediatrics, and a faculty for the World Federation for Safe Anesthesia, Pediatric Anesthesia, as well as many short course involvements, including the vast vital anesthesia simulation training and high risk and pediatric workshops. And I have very happily participated in short courses with both our presenters today, and I can say that they are very much well versed in this topic, which is appropriate for our paper today, which is the priorities for content for short course and postoperative care relevant for low and middle income countries, an e-Delphi process with training facilitators. Now, postoperative care has had much more attention, much deserved attention than it has previously. So this topic is very timely and appropriate and important for consideration. So it's very, very welcome to have the two presenters today speak to us about this paper and about postoperative care. So without further ado, I'll hand over to Dr. Sailaja, who's going to present the topic and the paper. Followed, Dr. Gita Nath will add some comments, and then we'll open it up for discussion. So Dr. Sailaja, without further ado, please.
Thank you, Ryan, for the introduction, and hello everyone. Good day to you all. Let me start off by sharing my screen. Is my screen shown?
Yes, I can see.
You can see it. So as introduced, I'm Dr. Sailaja from Rainbow Children's Hospital, Hyderabad. and we are located in India. And I and Dr. Gita Nath are a part of this study that was done in the previous year. And this is about the priorities for content for a short course in postoperative care and relevant for low and middle income countries. It's an e-Delphi process with training facilitators. I and Dr. Gita Nath have been part of WFSA SAFE courses for a long time now. And we have trained many participants so far. And so we were included in this study as part of WFSA facilitators. So we have our study was published in Anaesthesia journal in 2022. And these are the other authors with us. So I'll be dealing with this topic under these subheadings. So what is it that prompted for this study to take place in the first place? It is because there are a lot of short courses available right now, which have been done since quite some time, like the WFSA SAFE courses, which are basically important and take into focus the pediatric and obstetric anesthesia. And these courses have been going on for quite a while, and they have been analyzed like regarding how the participants are benefiting from them. So there is a lot of improvement of skills and the confidence and the teamwork abilities of the participants. This all has been observed because of the analysis. And we think more and more short courses should come up for different critical events or different critical areas of work in our field. And there are also other courses, multidisciplinary course on operating room care and basic low resource courses. All these courses have a little bit of postoperative care in them, but the whole of it, very comprehensively, it is not covered, I would say. So that is the reason it was taken up as a study, and we started working on this. So it was aimed to collaborate with established SAFE course facilitators from low and middle income countries to define the key components. What can be the items that will be taught under a proposed short course postoperative care for postoperative care and complications short course. And the teaching formats, the participants, the facilitators, who will be and how it will be done, everything was discussed in detail along the process, and specific course content created. So the objective of this study was to develop a short course for postoperative care of the patients. So coming to the materials and methods, ethical approval was obtained from the Oxford Tropical Research Ethics Committee, and this study was done by a Delphi process, which is a systematic method to determine agreement on topic through consecutive interactive sessions. We had multiple Delphi processes from different geographical areas, and it was done in English, Spanish, and French languages, and multiple languages, and all the rounds were attended by a panel of experts from WFSA SAFE course facilitators, and they remained anonymous so that proper processing is done. So to those who are new to the Delphi process, it is an organized method for collecting views and information pertaining to a specific area, which in our case was to check on what items can be included for a short course for postoperative care and complications in the post-op. And this involving all the different experts from different geographical areas, and a lot of information was gathered through different processes, and assessment was done, evaluation was done, and finally we came up with what is apt for the short course. So the items included in this process, in this Delphi process, were items related to the content for a potential short course on post-op care and complications, and the teaching methods, the participants, and the faculty. So these are the different geographical areas from where the experts put in their inputs. The WFSA SAFE course facilitators are all over the world, and around 868 anesthetists were invited initially when the study actually started from 45 different countries. And then finally, 86 of those experts responded, and so they belonged to these different 4 regions. And it was initially decided that if a region has less than 10 panelists, then that region would be included with another region. So Western Pacific region here was included with a Southeast Asian region. The modified Delphi process was used here. The exact process of Delphi is actually little changeable, and no exact process is well defined for it. And modifications have been done previously also. So in our case, we wanted to reach out to a larger group of experts and decrease the carbon footprint and derive a global perspective to this study. So it was done fully online, and eligible participants also joined in any of the Delphi rounds. We had 3 Delphi rounds going on. So participants could join in any of the 3 rounds. So that was a good thing done, because there is a lot of fallout and addition also that keeps happening. And the Delphi process took place from February 2021 to May 2021. And then the triangulation phase was there, wherein all the data from different things, different regions, everything was accumulated and compiled onto a website with the option to leave a feedback. These findings were placed on the website in July 2021. And there were a lot of clicks on the website too, around 201 or so by the time this got published. And some 10 people left comments also. 9 of them were actually already short course facilitators like us. So this is the flow chart, which is showing the stages of the study process. And the short forms have been explained here: African region, American region, Southeast Asian region, and Western Pacific region. I will go through this one by one in the next few slides. So how was the information needed identified? Like what are the items that can be included for a short course on postoperative care? So literature review was done, and studies based on postoperative care in low and middle income countries were looked into. As such, postoperative mortality, morbidity is quite high, and that is one reason why it was decided to go ahead with this. And also in low and middle income countries, the morbidity mortality is much higher than in other regions. So specifically, this area was also chosen. So exploratory focus groups, that is the WFSA facilitators, included around 25 items, from literature 70 items, and the core study group, the study initiators, included around 13 items. So total of 108 items were included in the study initially. So the review was done, and a pilot survey was done to see what all can be included for this short course, and who can do it, and in what way it needs to be done. So there were initially, this process took around 3 weeks. In the first week, consents were taken, and confidentiality was maintained, and the process was explained to each and everyone. In the first week, the postoperative care and postoperative complications topics were discussed, like where they work and who provides care after surgery, who is the important person who can take care of the patient in the postoperative period. Questions like this were discussed, and a lot of answers came up. And regarding the complications also, what types of complications have been seen by all of them, and what are the most important complications, why they are the most important, and who should manage the complications, when is the patient most at risk for complications. All these questions were discussed in detail and noted down. And in the second week, how do we teach on such a short course? This question was discussed in an elaborate way. And as we were all already involved in teaching on a short course, we had a lot of inputs to give. And even the COVID-19 pandemic had created a lot of change in our views. Actually, when we were doing WFSC safe courses before on-site, we would have some 20 or so of participants. We would have a 2 to 3 day course, and the participants would be mostly local, and the faculty, sometimes national faculty arrive, and sometimes international faculty too. When COVID hit, it was completely different for us. We could not conduct any on-site courses anymore, but life had to progress, and we decided to do an online course, which actually went on very beautifully. We were quite skeptical about it, how we'd be able to reach, how would we be able to maintain the tempo between the participants and the facilitators, and how do we make them, because there is no hands-on exposure for the participants. So how do we make this better for them? All such issues were discussed, and a lot of preparation was done separately for that online course, because in on-site course, we would ask the participants to enact certain roles, and the role play would come out, and we would discuss about what happened and all. But there is no way that can be done in an online course. So what we did was we enacted those roles and put up the video first, and then we discussed about the particular situations. And also, like, we had to keep them engaged. So we had to continuously discuss with each person separately. We had to keep it in mind that each one should not be left out, because if they are in front of you, right in front of you, it is very easy to communicate. But when it is online, it is difficult. Such a didactic lecture would be easier online, but in communication, as a discussion, that is a little more tougher, and we have to keep it in mind that we have to keep all the persons involved. But the plus of that was that we could have participants from all over the country also, as well as from outside countries, other countries. Like few participants from Pakistan, Afghanistan were also there, which was quite surprising and happy thing for us, because we had other people, other situations which we could discuss, and it was quite a unique way to deal with. So that's why the online teaching also, online method of short course teaching also was proposed by many of the participants here, many of the panelists. And regarding who to teach, who should teach and who should participate, there are a lot of discussions and a lot of proposals regarding who should teach and who should participate came up, and we'll be seeing that in the next few slides. And in the third week, all the content was shown, and discussions happened if anything different should be added, and how to reach the intended participants for this study, that is a safe course facilitators, and it was closed in the third week. And all this data was captured onto a computer software. So I told you there is a deviation this African region, round 2 had lesser response rate, and so a post hoc definition was done for this particular region, when an item would be included in round 3 if it was ranked 4 by 64% or more of the panel. For the rest of the groups, it was if it is ranked 4 by more than 70% or more of the panel, because many of the items would get excluded if the a priori analysis was used. A priori in the sense, it is coming from theoretical deduction only, rather than from observation or experience. The observations and experience of the facilitators were utilized in this process, and because of the low response rate, this change had to be made. And so these are the 5 themes that came up finally after the focus on the 3rd round. And these include patient and health system considerations before surgery, anesthesia and surgical care during surgery, and monitoring of the patient after surgery, ability to rescue the patient with surgical complications, common complications after surgery. So these are the items that were included under patient and health facility. The items shown in red would have been excluded if the deviation in the African group had not been made. So several issues regarding the prognosis and risks after surgery, delays in reaching surgical care, staffing issues, short-term health issues, age-related issues, all were included in this category. In the intraoperative category, all were in agreement, and all of them were included even in the African group. Here, regarding the anesthesia and the surgery, there were several inclusions for each item. And next, monitoring, a few of them would have been excluded if the deviation was not made. Location of care, effect of nursing, availability and level of training, role of physiotherapy, critical care outreach services, these would have been included, but for the post hoc change. So complications were all included, system-wise complications were included, effects of COVID-19 infection were included, and management of pain and nausea and vomiting was also included. Complications of ICU stay were also included. So coming to the ability to rescue, capacity of ward staff to manage critical events was included, management of acute pain, availability and prioritization of resources, and referral service also was discussed. So the teaching methods, when it came to teaching methods, a lot of different methods were included, like the discussion group, the small group workshops, simulation, high fidelity simulation in a dedicated simulation suite, and pre-recorded presentations, case stories from healthcare providers, all these were included. Facilitators were proposed like surgical providers and surgical specialist provider, physician anesthesia specialist providers, and international faculty also were included. Regarding international faculty, there was a low response, like most of them felt that the course can be conducted without involving. We'll discuss the details about that later. And several participants have been proposed by everyone. And this is anesthesia providers, general practitioners, nurse anesthetists, anesthesia technicians, critical care nurses, operation theater nurses, and other non-specialist operative service surgical providers also. So data management and analysis was done, as I told you initially, with the Likert scale, assessing the frequency of responses. And this all was collected and managed using RedCap software. And then data analysis was undertaken using R4 statistical analysis. So what we found in our analysis, the common things among all the panelists from all the geographical regions were that most items on common complications should be included on a short course. So they were all in agreement about the common complications. Or they also felt that fewer items can be included under postoperative monitoring or preoperative patient considerations. And also across all these themes, multiple items were identified as important to include under short course by all of those panelists. So little differences may be there, but overall, all of them had inclusions in all of the 5 groups. And all regions felt that preoperative topics could be the least important focus. So what were the differences among all the panelists? Or among all the groups of panelists. So the main, most important theme to focus for the short course was different for each of the geographical regions, with the African panelists saying common complications after surgery is the most important, with the Southeast Asian region and Western Pacific panelists saying that the monitoring of the patient after surgery is of utmost importance, and the American panelists saying the intraoperative topics are the most important. Also, the preferred duration for the short course was also different, with the African panelists saying 4 to 7 days is required for the short course, whereas the other panelists agreed that 2 to 3 days is sufficient. So there was high level of consensus within regions regarding what is important for the course content. But outside, between regions, it was quite different, as we saw that they had different topics of importance. This says that in their setup, they face different kinds of issues. The issues are not same all over the world. Like post-op care has like intra-op issues important for some geographical areas, some had other concerns. So overall, when we get to have a look at this, if we create a particular universal curriculum for this short course, then it may not actually meet the needs of all the geographical regions completely. And some issues may be missed out, and some issues may be not necessary to be discussed. So that may eat up the time, and the participants may feel that they're not getting what they want from the course. So all these things, if we keep thinking about it, we find that maybe we should look into a different way of creating a short course. Like you can have several modules of topics, and you can include those topics what are required for a particular region, wherever we are conducting that short course. Who are the participants? Based on the participants also, the content can vary, because if it is, let us say, post-operative nurses, they will have their own set of problems that they deal with on a regular basis. So if we give them the content that makes them more capable of taking care of those issues, so they will be more happy, as well as it is apt for them. So that way, course has to be streamlined and conducted rather than having a universal thing for everybody. So universal curriculum has been followed so far by different short courses. But going forward, I'm thinking mostly this module-based short courses will be more common coming in the later years. Also, anesthetists and operation theater nurses were considered to be the key participants by most of the panelists, but the African and American region panel recommended more multidisciplinary healthcare professional per participant roles. Yes, actually speaking, if you think of it, if only one group in the whole team, one person is trained from among the whole of the team, then the results may not be that plausible. And so if everyone who's involved in the post-operative care of the patients is trained together, that would have a better impact on the actual outcomes in the patients, is what I'm thinking. And anesthetists are the key facilitators according to most of the panelists. And it has been so with the WFSA courses also, but involvement of other like others, like the surgeons or the nurses, as facilitators, I think would make the participants, like if the participants are nurses, they would relate more to a facilitator who is a nurse, and they feel more confident, and they come out with, they participate better in the course is what I think. And so even when different facilitators are there, it is a team in itself, like a surgeon is there as facilitator, anesthetist is there, nurse is there. So they themselves are literally forming a team over there, a strong team, which can take care of post-op complications. That is what will be reflected onto the participants also. Also, faculty from high-income countries were not considered high priority, most probably because there is a lot of travel involved, a lot of cost involved, and a lot of carbon footprint. And also, we as WFSA facilitators have gotten used to conducting the short courses since years now, and we think we can manage it on the regional level. It is easier. But online mode of teaching should not go away, I feel, though we are going back to the on-site teachings. I think a combination of online as well as the offline mode would be a better way of going forward with the teaching, so that there is not too much of travel and the international faculty can participate. International the influence, like what they do in their setups and all, that knowledge can be imparted, and that will give a global perspective to all those involved. And that is how we will be able to grow together. And the participants also, I think they will benefit from a global perspective, and they will also come forward to be facilitators. So during our study, there were dropouts between each stage, which was expected, and reduced response rates were there because this most probably is due to COVID-19 situation, which was very rampant at that point of time when the study was in its final phases. And so maybe that could be the issue. There was a lot of stress about COVID back then, and we were not really very much up to doing anything else. And also ERA's concepts and enhanced recovery after surgery. These concepts are coming into picture for the low and middle income countries also, and we are actually following these concepts in our post-operative patients and seeing wonderful results. So these concepts also need to be included in the courses going further down. And it should be a dynamic, not a static, like we have developed a curriculum and that's it. It should not be that case. And further going down the years, it should keep on evolving and including the better concepts that keep coming up. And then the course would be much stronger, and the post-op outcomes can be improved well. And as I already said, multidisciplinary panelists and the development of multiple modules would go a long way in making it a stronger and better course. So coming to the conclusions, our study provides an outline of key content to consider when developing a short course on postoperative care and complications. The whole of the 108 items and the inclusions and exclusions, everything are displayed on the online, and everyone can go through those things. If you people have any doubts and all, you can get back to us later also. And the content, we feel, as I already told you, it should be guided by specific needs relevant to the location where the course is being held rather than by a universal curriculum. Thank you.
Thank you, Sailaja, for your presentation. I think it came out well. So, just to add my 2 bits, as Sailaja said, we've been involved with safe courses since 2017, when WFSA started a 4-year project in Telangana. Telangana is where Hyderabad is. And that's how we all came into the picture. And this particular study was actually started because there is the safe OR course, there is the trauma course, but there was no course which is focusing specifically on postoperative care. So it was felt to be an area of need. So that's how the whole idea came up, that we should get some consensus regarding how and what and who should do this course, that kind of thing. So the participants of this Delphi were all safe instructors. So everybody had a perspective of how these courses are conducted and why they are being conducted as well. Because we know, I mean, the whole idea of the safe courses is that you don't have to teach everything, but everybody should come to an acceptable, safe standard of practice. That is the whole idea of the safe courses. And so anyway, so that's the reason this whole thing about having a postoperative a course about postoperative care came about. Then, in fact, one thing comes out of another. Like, we did the safe courses, then we got involved in the vast course, which is something you guys should look at as well. If you get a chance, ask Ryan, he'll be able to tell you about it. And there are these different courses, and the emphasis is different. Like the safe courses we want to get this particular content across to the participants. We want them all to receive this content. Whereas if you look at the vast course, it is, okay, little bit about the content is important, but much more than that is the interactions between people and how we all work as a team, and what problems they had, how we debrief. So all those things come across in the vast courses, which I strongly recommend that you guys look at and take the course if you get a chance. So, and then we have this new course coming up. A word about the findings. Most people, I think, felt that, there was agreement on teaching methods. The best way is small group teaching, because all adult learners, if you just keep giving them long lectures, they're not going to, be interested or listen. Attention span is also limited. But if you make them interact and discuss, get involved in the discussion, that is going to be much more effective in them carrying away, and maybe we will learn from them as well. That's another thing that we have to keep in mind, that we are all at the same level and we learn from the participants as much as they learn from us. And the variation between these regions is it's reasonable, because you have different ways of working, you have different facilities. Like Ryan was just saying, he's in Uganda.
Yeah.
And he's managing with very little. He's showing them how to give safe anesthesia with very low resources. I mean, the resources are different in different places, staffing is different, the setups are different. So naturally, there will be variation between the regions of what kind of things should be included and how you should conduct the course as well. Even during the safe courses, we had to modify things a little bit. Like some topics in the safe pediatric was not really relevant to us. We don't often see sickle cell. I mean, it's a rare condition. So we took that off. So we modified things to suit our circumstances and our population. And of course, as Sailaja said, we did the online thing because of COVID. So that was a great experience as well. Very rewarding. Little bit sense making, but on the whole, we had a great experience. So anyway, what this study that was done was a very painstaking collection of data so that we come to a consensus of what is the best way we can conduct short course on postoperative care. And in fact, we are in the process of developing a short course on, we are calling it the Safe PACU course. And we have people on both sides of the Atlantic. We have people in Africa and people in India participating in, we've started writing content for it, and hopefully, it will come to some kind of fruition. All this hard work won't go waste. So thank you very much. Thanks, Ryan and Helen. It was a great pleasure being here with you guys. And we are happy to take any questions or any comments, ideas. Thanks.
Brilliant. Thank you very much to both of you for that excellent presentation of that paper. The presentation itself and the comments that followed from you, Dr. Nath, that was excellent and informative. Apologies for the disturbance midway through, but that's okay. They had no idea they were interrupting a group of global surgeons and anesthesiologists. We thrive on adversity and challenge, so fool on them. So thank you for delivering that presentation. Now then, before I continue, just to say, we're going to add a feedback form in the comments section just to give us your feedback, just to help us improve going forward. But for now, if you have any comments or questions, please put them in the chat, or even raise your hand if you have the capability to use your microphone and speak yourself. That's perfectly fine as well. So either option, please do. While we're waiting for anything to come about, I'll just kick off. I just wanted to firstly say about the strength of this study and how, in looking at the different regions and being able to discriminate between the preferences for each region, which is something that sometimes it's all grouped together, and it's nice to see that and have the context-specific learning opportunities. I was just wondering, thinking about fixed curriculum versus modular aspects, do you think there is still room for the traditional model that's SAFE, for example, as put forward, in not having a fixed sort of homogenized curriculum that is focused on some basic level of safe care that may be applicable globally? Or do you think that the shift really needs to happen for all groups now, where we're going towards a more modular, context-specific arrangement? I was wondering if there's room for both, or whether that shift has to happen absolutely.
There is definitely room for both. Universal curriculum, see, few of the modules are needed for all the regions. There were commonalities when we checked on all the regions. So yes, there should be some common modules which will be universal, and that curriculum will be fixed. And the rest of the modules can be picked and chosen by the regional faculty for their own participants. That would be, I think, more apt.
The other thing is, like, if some area is different in some area of management is different in, say, Africa from India, like you're training non-physician anesthesiologists. We are not allowed. We're not allowed to have a non-physician administering anesthesia. So when that kind of thing is there, you can actually have alternate models. So we have a lot of common modules, and we can have, for one particular module, we can have this for, say, Africa, and the other one for, somewhere else, that kind of thing. So I think there is a lot of room to innovate and play about with this and see what works best. Does that answer your question?
Yes, great. Thank you very much. That's what I thought. Yeah, having that mix is the way forward. But I think what's changed is the appreciation, I think, more of the modular context specific. I think that's the shift. What's come before is still required, but that shift to that modular context is what's in my thing, I believe. Fantastic. Yeah. So, feel free to raise your hand in the chat, or in the meeting chat, post anything. But just while waiting, I just want to ask something more specific to some of the results. So I was noticing about the people who help generate the content, the anesthesia providers who helped generate the content and receive the questionnaires, were mostly physician anaesthetists, so 88 to 97% across the regions, I think was the result. And do you think if the content generators were from different cadres, for example, nurses or non-physician surgeons, do you think some of the focus in what would be required would change at all? For example, in the ability to rescue category, which is an area I'm very interested in, there were a few items for the African and American regions, and one of the focus points that wasn't there was the ability to escalate care, which may be not so much of a focus if you're already a physician anaesthetist, for example, but maybe of great focus if you're a ward nurse, perhaps the ability to actually escalate. Whereas basic monitoring and EWS were 100%. So you do the monitoring, but then the ability to escalate was not so much of a focus. I was wondering if people who, for example, ward nurses or non-physician anaesthetists, whether a focus item such as that, the escalation or other items, maybe they would have more focus and more priority from their point of view. From
included in the, if they had been included in the study, is that what you're saying? If
Yes.
Yes, for the content generation, just
yeah, absolutely, because they will have a different, perspective and focus, and also among the faculty, they would feel more comfortable. I think Sailaja mentioned that, because they would be on the same wavelength, when somebody is teaching them, so that, they don't feel that, oh, someone is coming and talking down at us and telling us something which we are not familiar with. Whereas, they can have a much more comfortable interaction. But the problem is, the whole course, the whole study started with looking at providers or instructors for safe courses who are mostly anesthetists. So that factor couldn't be helped, because most of the safe faculty are anesthesiologists.
Yeah, it was specifically taken up because it was a pandemic situation and it was difficult to reach out to other faculties, and this is a group which has already been doing short courses, and they will be more pro to working in this study, is what was the reason behind choosing WFSA facilitators.
But in fact, the people who are developing the safe PACU course, we have some, nurses and nursing administrators and people like that who are writing some of the content. It has to be a combination of both, isn't it? Especially in the PACU or in the post-operative period, it is so much focused on the nurses taking care of the patients, isn't it? So we have to have input from them.
Absolutely, I couldn't agree more. And I was going to ask about whether SAFE would develop a post-operative course, and it sounds like you are, so that's going to be interesting to see the development of that, but definitely. Thanks very much. Helen, please, you have a hand up.
Yeah, hello. So fantastic presentation. Thank you. That was really engaging and interesting. I just wanted to ask about what your thoughts are about clinicians doing research in sort of very educational fields. I think this is something that's growing, and it's certainly something that we're involved in with GASOC. We're doing a lot of work with FRIMS, of virtual reality group, who are doing surgical training and anaesthetic training now. And I just wonder, because I know we've come across some challenges, whether you've faced similar challenges or whether you've engaged with sort of people who are formally trained in education and course development. What do you think the challenges or opportunities are having clinicians doing research in an area of assessing education, and how do we best engage with specialists in that area?
You mean like actually trained teachers versus us clinicians who are not formally trained educators? Yeah,
exactly. Like, what do you think? Like, what I think it's quite a difficult interface sometimes, because you have people who are trained as clinicians trying to change the education of clinicians, but sometimes it's good to kind of have educators involved. And I was wondering if you if you had anyone involved who was sort of from a more educational background, or whether that's something that you, as the researchers, had to learn within the process you were doing, obviously with the Delphi process and other things.
So we have been working and teaching. I have been working and teaching all my life without actually being formally educated in education. Till I took my first ACLS course, when they taught the principles of adult education and all that stuff. It was great because it just added a dimension to what I could give people. Because till then I had not realized there was so much in the technique of educating people. So we don't have so many formal educators with us in our group. So we take on the role of educators as well. Is that accurate, Sailaja?
Yeah. So most of us are clinicians only, but yeah, involvement of specific educators maybe would make a difference. But to find educators who can be involved in this process is the difficult task, I would say.
One thing I have noticed is that when somebody branches off and goes totally into education and loses touch with their clinical skills, it's not the same thing because their perspective changes. I mean, when people, you must have seen when people become professors of anesthesia and they're doing high-level research into something, the clinical skills are not always, and clinical perspectives as well. So I think it's, if you're doing clinical studies, you should have a bit of both.
Yeah. Because clinical situations keep evolving. It's not like what we were doing 10 years back, we are not doing now. If somebody is gone into education only 10 years back and is trying to educate us as clinicians now, there will be so much gap between them and us. So it is better for the educator to educate us when they are also a clinician rather than somebody who is separately totally uneducated probably.
What were your challenges you were saying?
Yeah, I think those are some really interesting answers, because I do agree with what you're saying. And I think our field, surgery, anaesthetics, obstetrics, they're apprenticeship skills, and therefore your educators need to also be at the sort of coal face doing the work. So I absolutely agree with you.
Yeah.
I think one of the biggest challenges is how you robustly assess education of medical and clinical skills, and that's something I think most clinicians don't know how to do, and I just wonder if there's a vast expanse of skills out there that if we connected more clinicians with people who had more skills in education. And I think you were talking about some of the formal courses, things like ALS, ATLS, I don't know what else there is globally, but I think those are some good examples where there's been some good collaboration of sort of formal education with clinical expertise.
And they do assessment in a very specific kind of way.
Yeah.
Whereas when maybe we are coming to it now, but traditionally assessment of say anesthetic training or whatever, apart from the exams, has been subjective.
Yeah, so I think it's a new area. I think it's an area that's growing, and I think through experience, people like yourselves do become expert in both, but it's a lot of sort of trial and error rather than formal education, and that's not a bad thing. It's just an interesting thing to think about. Anyway, I'll let somebody else ask some questions. Thank you.
Thank you, Helen. Anyone else? Please just feel free to raise your hand. The raise hand function, and I'll ask you to introduce yourself, or just put in the meeting chat, and I can ask it. I'm very happy to do that as well. Let's just wait for that. While we're waiting, I just want to pick up, since we're doing a remote session with people around the world, I want to pick up on some of the comments made both in the presentation and the paper regarding remote teaching and learning, and really focus on the paragraph made on the importance of carbon offsetting in global research and teaching. And it kind of goes hand in hand with the interesting finding of the low importance of international faculty. It was ranked low, wasn't so much required now as that shift happens and more training is occurring on these sites. So firstly, the importance, whenever a paper is published, the importance of mentioning that carbon offset and the importance of mentioning the efforts made in that regard. Do you think that's something that should be a main focus for all research and globally done now? And
Sorry, I didn't catch your question.
It's got cut off.
Ryan?
I think Ryan might have gone off the call. I think there was an issue with his connection. I don't think we got his whole question, so maybe we'll wait for him to come back on. Just want to give an opportunity for anyone else on here that we can see. Adane, Patrick, Alison, Fiona, Becca, Favour. Do any of you have any questions whilst Ryan's reconnecting?
I'm back.
Oh, I think
Can
Fiona.
you repeat your question, Alan? Okay, right.
Apologies, I had a bit of an internet issue there. I'm not sure where I got to, but essentially I was just, speaking about the importance of mentioning that carbon offsetting in global research teaching publications, really making a specific section on that. And just the fact that online methods were ranked low, is that truly a resource limitation? And is there still a desire for that? Or is there still a usefulness for the online methods, a way of teaching as we come away from the restrictions of COVID now, hopefully, whether that appetite still exists and is still practical?
As Sailaja said, we have to have a combination of online and on-site teaching. So it would help if most of the teachers and participants don't have to travel much. They're all in the same geographical area. Whereas if somebody has to come from outside, I mean, that is a huge, big carbon footprint, isn't it? But you gain from knowledge and perspectives coming from outside as well. So maybe, some of that can be on, in person, and some of it can be online. So it can be, everything can be combination of online and on-site. But as we were saying, we have to think about the carbon footprint of, especially, international travel.
Though the study itself was done totally online, but what further is going to be done regarding the study, like a short course is created, then what happens? It is conducted somewhere. So definitely travel is there from the national faculty or some of the participants coming from elsewhere. So further down the line, we do see that we are definitely increasing the carbon footprint. But we try to limit it as much as possible. Regarding online education also, there are a lot of issues with the internet connection, that the glitch we had just now, so that can keep happening. And then the education doesn't really happen in a streamlined flow. So that then the participants really are distracted, and in online, they keep doing something else along with doing the course. That is one thing I've noticed in online courses. The participants, then they feel that they don't need to take leave from work, and they keep working as well as attending the course. So whatever just we want to give them, whatever education we want to give them, that doesn't go in wholly is what I feel. That is why I'm particular that it should be on site with online content, of little bit of online content, so that we do have a overall global perspective, but still we have the participants' total attention also.
We faced some of these challenges when we did the online SAFE course in 2021, was it? 21. So well, you don't know whether they are just connected. You can see their name, but are they there or not? We don't know. So what we did is, we did like, mini attendance rotas, like after each module, we gave them a few questions and they have to answer it. So if they answer it, we know that they have attended and they're there, because just imagine maintaining your attention for the whole day is, not going to be easy for anybody to, keep focusing on the screen continuously. We gave them gaps, and we did this, repeated, like we have the pre-test and post-test, but we broke it up so that we did it several times and used those as like an attendance, that they marked their attendance, that kind of thing. So all these are the, and of course we couldn't assess skills. If you're going to teach skills, it has to be in person, whatever the carbon thing. But somebody doesn't have to come from across the sea to teach the same skill. Whoever is there can teach it. Because there are people.
Right, thank you very much. Oh. Thank you. And yeah, it was good timing on my part to show the limitations of remote teaching with internet glitches. So I was happy to do that. Great, fantastic. So I think unless there's any final points, I think we'll leave it there. Unless there's any final questions that anyone would like to ask. I'm just having a quick look. Any hands raised? Please come in. No, nothing there. I think that's us. Fantastic. So just to finish with a very warm thank you to our two speakers, Dr. Nath and Dr. Sailaja, for the presentation. Thank you very much for joining us today on a Saturday. And thank you for presenting the paper, which is, again, as I mentioned at the top of the bill, very timely and important subject in postoperative care, and combining that with education, which we spoke about thanks to your question, Helen, which is also wrapped up with this. So two really big and important topics. So thank you for bringing it to the attention. Thank you. Thank you very much. So before we move on, just a reminder of feedback, please, for the attendees. That will be sent out, I believe, via email, but is also in the chat function. So please do complete that for us. That helps us with all our future events. And speaking of future events, our next GASOC Journal Club will be on March the 29th. That's preliminary dates. They can change, so keep an eye out on our social and email and so forth. That's currently, though, March 29th, 7 p.m. GMT. And interestingly enough, that's going to be with Professor Picard and Dr. Vickery regarding the ASOS-2 trial. That's the African Surgical Outcomes Study 2 trial. So again, linked to postoperative outcomes. So a very strong postoperative theme, thus emphasizing the timely nature of the subject, as I mentioned. So that's excellent. And then, as I said at the beginning, the 2nd of February is our introduction day for the launch event for the Frugal Innovations course, which I encourage everyone to attend. And that's a launch event for a subsequent 8-9-month course, monthly modulars, all free to attend. So please have a look at that. So I think that's all, unless Helen, is there anything you'd like to add?
No, that's fantastic. It's a really, really interesting session, and we'll be putting up the recording onto our YouTube channel. I'm sure people will be catching that up, so I'll stop that now.